Now you can.
Okay. Hi, everyone. I'm Tom LeGrand. I'm the president of the IUSSP, the International Union for the Scientific Study of Population, and I'm thrilled to welcome you today to this webinar on COVID-19, the pandemic's consequences for adolescents, a topic which interests me personally quite a bit. This event is part of a new IUSSP webinar series, and most of the webinars so far have focused on aspects of the COVID-19 pandemic, though that will not always be the case. The next webinars will start taking place after the IUSSP August vacation break at the end of August. We will have a series of 4 webinars taking place from August 31st to September 3rd on different aspects of the COVID-19 pandemic for sexual and reproductive health in Africa. IUSSP members will receive an invitation to register for these events. Non-members should keep their eyes on the IUSSP website for news of upcoming webinars if they're interested in following them. I also want to let participants know that the IUSSP has set up a new web page on resources and links to demographers' contributions to understanding COVID-19. Today's event is organized and run by Shireen Jujuboy, the Vice President of the IUSSP and a very prominent Indian demographer who has worked a great deal on adolescents. I'll turn the mic over to Mary Ellen Zupin, the Executive Director of the IUSSP, who will briefly explain how this webinar will work, and then Shireen will take the stage and moderate the webinar. Thank you for coming.
Hi, everyone. I just want to very quickly explain to you how we're going to do the question and answer. Basically, you need to use the Q&A. It's in the middle of your screen. Click on that, open it up. Vote up questions that you like so that we know which ones to answer, because we're likely to have very many. When you do write your own question, if it's for a specific speaker, kindly put their name in your question so we know who to direct it to. And finally, if you'd like to ask a question or leave a comment by speaking yourself, hit the little raised hand and we'll try and accommodate you. We ask that you keep your speaking time to 1 minute or less. This will happen at the very end. Anyway, welcome and glad you're all here. And now I'm going to turn this over to Shireen Jujuboy.
Oh. Sorry, there's something about after the webinar. Mary Ellen, you want to take that? Oh, okay. So, thank you, Mary Ellen. I don't think I need to formally introduce this eminent group of panelists. They're well known for their work. They've done pioneering research on young people's health and development, and they have a lot to say. But I do need to say how grateful IUSSP is to all the speakers for agreeing to speak, and to all of you for being with us today. We changed the order of speakers a bit. So now the first 2 speakers will be Leticia and Santhya, as you see here, focusing on findings of their recent research. And then Joyce will provide insights from program effects. But before I turn over to them, I'd like to provide a broad brush picture of what we know about at least some of the consequences of COVID-19 and lockdowns on young people's lives. Young people may not be the face of the pandemic today, but the pandemic is certainly exacerbating many of the threats to well-being and exercise of rights that they already face. And so I'd like to run through some of those. Yes, so on education, we know a remarkable amount already about effects on education. More than 1 billion children and adolescents are out of school, and this has resulted and will result in a range of consequences that have widened inequities. Millions of poor children have been deprived of school meals, although online classes have taken over everywhere, we know that there are many inequities, and these inequities are likely to affect learning outcomes. Poverty-related obstacles inhibit poor students and those in remote areas from owning or accessing devices and having uninterrupted connectivity. Some estimates I've seen suggest up to 50% had poor network access, some even more. And then there are gender disparities, which I think are widening in some settings. Can we go back to the education slide, please? That are widening in some settings. For example, in India, where more boys than girls own their own devices, and boys get preference over shared household devices. What will happen when schools reopen? The World Bank estimates that almost 7 million primary and secondary school students could drop out due to pandemic shocks. And of course, girls will be more likely to drop out than boys. And with school dropout combined with household poverty, there is a fear of a spike in premature entry into unsafe wage work. Coming now to sexual and reproductive health. Yeah, the next slide. What we know here comes largely from various estimates of the effects on the general population. And these numbers are disturbing, as you see. Disruption in access to pregnancy and abortion-related services is estimated to result in an increase of between 12,000 and 57,000 maternal deaths. Disruption in access to contraceptive supplies, depending on the duration of the lockdown and extent of health service disruption, will deny between 13 and 51 million women contraception and result in between 300,000 and 15 million unintended pregnancies. And a 10% decline in services in low and middle income countries will lead, as a result of these additional unintended pregnancies and lack of services, to 3.3 million additional unsafe abortions and 1,000 additional abortion-related maternal deaths. Now, these numbers have huge implications for the young. Effects are likely to be much more acutely felt among them than the general population. We know that they already have higher unmet needs. Many are denied the agency and freedom of movement to access supplies and care. Many lack confidential and non-judgmental counseling and services. And with the closing of schools and safe spaces programs, they will likely further lose out on these. On mental health, we are learning a lot already about mental health effects. In the general population, for example, one recent review of studies by Brooks et al. Has documented an increase in negative effects, including PTSD symptoms, confusion, and anger. And among the young, studies are increasingly observing symptoms of anxiety and depression, and these are higher among girls than boys. You see a remarkable similarity between these two studies of high school students in China and a comparison of pre-post-lockdown feelings of anxiety, not using identical indicators, the authors say, but you see an increase from 34% to 42%. So while these symptoms are widespread, counseling and helplines, as we saw earlier, including school-based, are becoming increasingly inaccessible, which will then exacerbate mental health problems and so on. So then coming on to violence, we've seen a spiraling pandemic related to of violence against women and girls in many countries, and UN Women has called this a shadow pandemic or the silent pandemic. Here too, we know that girls and young women are at particular risk of violence within and outside the home. Emotional violence, physical, sexual, cyber violence, trafficking, transactional sex, and so on. And we've seen these in previous disasters and crisis situations. For example, during the Ebola outbreak in West Africa, girls and young women experienced more sexual violence, coercion, and exploitation than before. And there are reports now of increases in helpline calls from girls and young women, in some instances up to 25%. But we know that these are probably only the tip of the iceberg. More limited access to phones and privacy from, and lack of privacy from the perpetrator are not going to allow girls to be, and young women to use helplines. And then there's the loss of social networks. So it means that whatever help-seeking options used to be there have been cut off from them. And finally, child marriage. There's a UNFPA estimates, can we go to that? That the economic downturn and stalling implementation of programs will result in 13 million additional child marriages. And we've seen this earlier also as a consequence of several disasters and crisis situations in South Sudan, in Sierra Leone during Ebola, in Bangladesh and India during droughts and famines and floods. And already in India, for example, there are several media reports of spikes in child marriage. What we know from previous experiences is that marrying off girls is used as a coping strategy to address poverty. One less mouth to feed, lower dowries, perhaps getting bride price, and to so-called protect the family honor and girls' security in uncertain times, already noted in a report by Plan International. And so in short, consequences for the young are huge, likely overturning much of the progress we have made over the recent past, and perhaps having longer term effects also. So that's it from me. Now let me turn over to our speakers, and starting with Leticia.
I was muted. Yes. So good morning, good afternoon, good evening. I'm delighted to be here, being part of this panel. I want to thank Shireen, Mary Ellen, Tom for organizing. This is one of the unintended consequences of the pandemic, that we are able to do these kinds of things more easily. So I'm delighted to be sharing my research here. So we were on the field collecting data on the long arm, the consequences of the Zika epidemic, the reproductive health consequences of the Zika epidemic in Brazil. When the COVID pandemic hit, and at first, our goals were to look simply at the consequences of the Zika epidemic. So for example, how exposure to Zika, social exposure and risk exposure shaped pregnancy, contraception, contraceptive use, prenatal health care, abortion, pregnancy, and birth outcomes. As my friend Anne Biddlecombe would say, the world delivers in strange ways. So the pandemic hit, and right when we were starting the field. And so our goals now are to look into the consequences of the Zika epidemic combined with the consequences of the COVID pandemic as well. And specifically for the case of Brazil, to look at whether there is a double jeopardy from having two successive health outbreaks of international proportions, right? So why look at Brazil in this case? So Brazil was the country that was mostly affected by the Zika epidemic that ended in 2017. In our project, we look specifically in the state of Pernambuco, which is in the northeast of Brazil. It's denoted in red here on the right. And specifically, we look into those three mesoregions, Agreste, Mata, and the metropolitan region of Recife. Those regions have different climates and different socioeconomic indices within the state, of course. And we wanted also to look at how contextual measures or municipality measures of exposure to Zika and now to COVID would matter for intentions in terms of childbearing and reproductive processes. So why Pernambuco? Pernambuco had about 1/5, 17% of the cases of microcephaly that took place in Brazil during the Zika epidemic. So we have Pernambuco cases in blue there, and then the cases in Brazil. So the state was hit hardest. Now, why Brazil? Brazil is now on the epicenter of the COVID-19 pandemic. It has one of the highest numbers of confirmed cases and increasing cases as well. So here we have the United States. So I'd like to say those are my two countries, the United States and Brazil. So they're competing right now head in head. We have, of course, India right there as well, but Brazil and the United States are competing as sort of like currently being the epicenter of the COVID-19 pandemic. So what are we doing, or what have we done in terms of data collection? So I'll give you a brief description on that, and I'll jump right into preliminary results. So first, we are conducting the baseline of a longitudinal data. We were doing household survey data. That was what we had planned. And we switched to, let me ask you one question here. Yes, now that's much better, right? Thank you so much. So now, so we planned a household level panel. We had done the census listing of the households, and we had to stop and switch gears and change to phone data collection. Now we are doing random digit dialing based on cell phones. In the state of Pernambuco, 88% of the women, the ages we are interviewing, own a cell phone, 94% in the metropolitan region. We are going to interview 4,000 women, and we have completed 1,200. We plan to follow this, the respondents monthly via WhatsApp or email. And we have already started that. And as I said, we completed 1,200 interviews. We are also collecting contextual data, municipal level data, social demographic data on Zika and COVID exposure. We also conducted 56 already in April and May. We conducted 56 in-depth interviews via Zoom through snowball recruitment. And again, these are women ages 18 to 34. And we started a WhatsApp experiment to see what kinds of response rates we would get if, for our follow-ups. with women. And WhatsApp is widely used in Brazil, much more than text messages. So today I'm going to talk about preliminary results of the baseline survey. Again, I will highlight preliminary because, again, we are in the field. So these are 1,200 interviews completed, and some results of the in-depth interviews as well. So this is just a quick design of the follow-ups, and I'll skip that. As Tom was reminding, there will be another a PAA seminar on this coming up, where we'll talk more about the data collection in itself. So just real quickly, this is a summary of our measures. As you can imagine, we had a long questionnaire that was face-to-face, and that we had to cut a lot. So now because of now it's phone. But we have household water issues, income loss, violence in the household, work, socioeconomic status, interruption of healthcare access, contraception, exposure to Zika and COVID, self-assessment of the probability of COVID and Zika infection. If the woman suspected she had Zika, dengue, COVID, pregnancy, live births with birth dates, childbearing intentions, contraceptive use, abortion, and attitudes. So preliminary results. So I organized this in response to Shireen's article, very interesting and provocative article on the consequences of the pandemic for young people. So essentially, I matched what we had in terms of preliminary results with the topics that Shireen discussed earlier. So in the case of Brazil, what have we found in terms of preliminary results? In more than 50%, 56% of the women reported the loss of household income. Only around 10% reported violence at home. But again, there's a caveat here. This is not a survey to address violence, gender violence or violence in the home. So it's difficult to capture that. About 73% reported working more in the house with household chores or childcare. So this is from the survey. The in-depth interviews confirmed preliminary results from the in-depth interviews confirmed the idea of like disagreement with family and household members, more work in the household, income reduction, and a large proportion of women in the in-depth interviews talked about uncertainty, especially financial uncertainty, anxiety, depression. High SES women talked, also mentioned improvement in sexual life, which is sort of like a positive, and more time spent with children. But there's a very clear SES stratification there. In terms of healthcare vulnerability, so about 22% of women who needed care reported that they did not seek care. About 15% reported that they needed and they were unable to find available care. Whereas about 8% said that they needed, but they chose not to because of concern with COVID. About 4 said that they needed and went, and the rest, I want to say 78% did not need care during that time. Now, if we look into pregnant women, that is higher, a higher proportion needed care and didn't go for care, either because they were unable to find an appointment availability, or because they themselves decided not to go because of fear of COVID infection. From the in-depth interviews, in terms of reproductive concerns, the topics that came up were confirmed that women were concerned about access to healthcare and concerned about an eventual pregnancy. The uncertainty and stress regarding the risk for pregnant women was a huge concern for women at those childbearing ages. And most of them don't want a pregnancy, which is not a new finding. That's what we find, but in this case, they specifically mentioned that the Zika and the Zika epidemic and the COVID pandemic strengthened their desire not to have children, or at least to postpone a pregnancy. And there's evidence of the consequences of that already published for the Zika epidemic. Going on in terms of reproductive concerns, we also asked in terms of intentions if women should avoid getting pregnant during the pandemic, and the majority of our respondents said yes, women should not get pregnant during the pandemic. 75% mentioned that they completely agree, and the majority said they either agree or disagree, the two bars on the left. And then we also asked specifically, would you be concerned, you know, with Zika and with COVID infection if you got pregnant? And for COVID, about 50% said that yes, they would be concerned. And for Zika as well, still, even years after the end of the Zika epidemic. It's also very interesting to see the self-assessment, how women feel that if they think that they are gonna get infected. And for Zika, about 17% of the women think that their chances of getting infected with Zika is either large or very large. For COVID, it's 57%, so 57%. So we can imagine the uncertainty and the stress that these women are going through, right? I mean, with the concern with getting pregnant and the probability, they think that their chances of getting infection are high. We also asked about whether we had a statement that was, there's nothing I can do to prevent a Zika infection. There's nothing I can do to prevent COVID infection. And about half of our respondents believe that there's nothing that they can do about the risk of infection of both Zika and COVID. So either completely agree or agree, which is also very interesting to see, sort of like this sense of helplessness. Now, the suspected confirmed infection with Zika and COVID and how. So we asked specifically if our respondents have suspected or had confirmed COVID and Zika separately, of course. And we asked if yes, confirmed by an exam, confirmed by a doctor, confirmed by both, and yes, suspected or no. And those cases on the left, the yes, confirmed by exam, by doctor, and by both, are what we would see in statistics, right? I mean, the reported cases, of course, if respondents reported, but what we don't usually see is the high proportion of people who suspected they had the disease, the illness, and they might have acted accordingly. They suspect they had it, they had that uncertainty, they had that stress, and they might have behaved differently in terms of childbearing preferences, in terms of reproductive preferences and outcomes because of that strong suspicion. So we have that for Zika and for COVID, and about a quarter of the women suspect that they had COVID themselves. We are also going to be working with a concept of social exposure, which is how many people, first of all, if women know people who had or suspected they had Zika or COVID separately again, working with this idea that if individuals see others infected, in the case of Zika, if they see an infected person or infected pregnant woman, or if they know a baby who had microcephaly, that might have an effect, a social psychological effect on them. So in terms of Zika, a quarter of the sample report that they know somebody who had Zika or suspected they had it, and it's half for COVID. that they had, that they suspected they have. So if we combine both, it's higher. Now, in terms, we are going to also be working with the number of people to sort of have a gradient of this social exposure. So how many people do you know who had or suspected to have the disease? And for Zika, it's 70%. I think 70% know at least one person who had Zika or suspected to have Zika. It's the non here. And for COVID, it's 89%. So at least one person that our respondents know that had or suspected to have COVID. So we can imagine the networks of that, the effects of that again. So again, as I said, those are preliminary results. We are in the field, we haven't finished, but we can I can propose some ideas that we will be working on. So first, the idea of outbreaks of new illnesses as chronic stressors in women's lives. And we saw that in the in-depth interviews as well. So women talked about their lives being way more complex with those two outbreaks. So for example, they have to be careful with water, with still water, the regular use of repellent in themselves and their children because of the Aedes mosquitoes. Now the use of hand sanitizers for everything, the use of face masks for themselves, for their children. So this concept of this chronic stressor that's a consequence of those two outbreaks. We also are finding that the knowledge and prevention are well internalized, particularly among high SES women, but the uncertainty and the stress and the complexity are high. Among low SES women, we have the lack of access to bug spray, the difficulty in keeping physical isolation, difficulty in getting access to the government's emergency help grant, job loss. So this is one idea we are going to be working on with the data. And so outbreaks of new illnesses, particularly those with reproductive complications, create extraneous circumstances of uncertainty and stress that can be particularly harmful to young women. Particularly its social exposure to a new illness. So the number of people who suspected or had the illness that women know, who are these people? So we'll be looking with the longitudinal aspect of the panel of the data onto how those measures will affect reproductive intentions and outcomes, either combined in terms of Zika or COVID or separately. Also, then the idea of young women's double jeopardy in Brazil. So the COVID-19 pandemic is unfolding in tandem with the recent recovery from the Zika epidemic. So two successive outbreaks of new illnesses with reproductive consequences bring complexity, stress, and uncertainty, with the potential to endanger the health of these young women in unprecedented ways and to increase inequities. And so the CDC on June 25th added pregnancy to the list of risk factors for COVID and regarded pregnant women have a higher chance of developing the more severe form of COVID-19. So the combination of the Zika epidemic and the COVID-19 pandemic make an imprint on how cohorts of Brazilian women experience reproductive health, pregnancy, and childbearing, and on the circumstances around which children are born. So that's what we are going to be looking at. So vulnerability, yes, uncertainty, stress, complexity, social exposure to two recent new illnesses, concern over infection for themselves and potential fetus and babies. And we'll be looking at the effects of childbearing intentions, desires, and outcomes. I want to acknowledge my great team who kept going, change data collection, check us out. And special thanks to all those people whom, you know, are amazing and have provided great collaborations and NICHD for funding. Thank you.
Thank you so much, Leticia. That was fascinating. I really look forward to knowing more about your measure of social exposure and how that comes out in the larger study. Now we're going to move on to Santhya, into a new continent. So Santhya, are you on?
Yes, Sherin, I have requested Mary Ellen to share my presentation. I have a bit of an unstable internet connection. So,
Mary
good
Ellen,
morning, good afternoon. I mean, I can try, but in case. Oh.
Okay. Go ahead, Santhya.
Thank you, Sherin, and good morning, good afternoon, evening. I'm very grateful for this opportunity. Findings from rapid telephone survey that the Population Council has conducted in two large states of India, Bihar and Uttar Pradesh, to understand young people's knowledge, attitude, and practices related to COVID-19 and its impact on their life. And I'm making this presentation on behalf of a team, New York as well as the India office. Just to give you a little bit of background about the COVID situation in India, we had the first case reported way back in January 30th. And during these 6 months, the number of cases increased from 1 to over 1.5 million. And, you know, currently we stand third globally in terms of the number of cases behind US and Brazil. And our recovery rate is about 65% and the death rate is about 2%. There are several measures being taken in the country, including a nationwide lockdown, which was in effect for more than 2 months. Testing has increased. As of now, about 18 million samples have been tested. There have been, you know, nationwide campaign to raise awareness about the symptoms of COVID, preventive measures using both conventional and the new digital media. Next slide, please. Yeah, who is sharing? And when the nationwide lockdown was introduced, the Population Council you know, made a decision to conduct a rapid study on young people's knowledge practices, drawing on an ongoing longitudinal study of adolescents. And that happened in early April. And then we went back to the same cohort. So my presentation is going to draw on these 2 rounds of the telephone survey. And it's going to talk about how young people's risk perceptions and prevention practices change between the 2 rounds of survey, and also how COVID-19 and the containment measures, particularly like lockdown, affected their jobs and livelihood opportunities, food security at the household level. They have, particularly the mental, Sherin has referred to, you know, the impact on young mental health, as well as access to their sexual and reproductive health service. Next slide, please. A little bit about this study. As I mentioned, this study draws on an ongoing longitudinal study of adolescents called Udaya. This work started in 2015-16, and it focuses on 2 large states of India in terms of population, Bihar and Uttar Pradesh, where we interviewed over 20,000 girls and boys aged 10 to 19. And the sample for the telephone survey drew on girls and boys who are aged 15 to 19 in 2015-16 when we first interviewed them, and who shared their telephone numbers with us and consented to be recontacted for future studies. And we had about 10,000 young people for whom we had telephone numbers. And for our first round of survey, we decided to contact, about 5,000 of them with a view to get at least 2,000 young people to be interviewed. And if the young person was not available, we try to contact their a member of the household. So for the first round of survey, we contacted over 5,500 young people's numbers, about 4,000 females and about 1,500 males. And you would see from this table that we had a response rate of 35% for females and about 43% for males in the first round. The biggest challenge we faced in terms of this telephone survey is that a lot of numbers that we had were either non-functional or non-reachable. And that was about 54% for females and 44% for males. The refusal rate at the first round was very low, about 2% refused to be interviewed over a telephone. And for the second round, we recontacted those who were successfully interviewed in the first round and consented to be contacted. So we had about 900 females for the second round and about 650 for the males for the second round. And our follow-up rate is 63% for females and 8% males. So there's a considerable attrition in our sample. And refusal rate also, as you can see, increased slightly. About 4 to 5% of the respondents refused to be re-interviewed when we approached them for the second round of the telephone survey. And the analysis that the findings that I'll be sharing is restricted to about 1,000 females and males who are interviewed at both rounds of the telephone survey. Next slide, please. So let's look at how young people's risk perceptions and prevention practices changed over time between these two rounds of survey, which is about a month and a half. Next slide, please. I'm not sharing some findings related to young people's awareness about COVID and its symptoms. In fact, everybody heard about COVID. They had a pretty good knowledge about symptoms. And what is interesting is that a lot of young people perceive that they are at no risk. At the first round, when the nationwide lockdown just started, we see that about 63% of males and 79% of females said they are at no risk, and they attributed their no risk to be like, they don't have a travel history, there is no COVID case in their neighborhood, it's more of an urban or an issue of the migrants. And when you look at the second round, you see that the proportion who thinks that they are not at all risk increased both among males and females, from 63 to 78% of males and 79 to 90% of the females saying that they don't think they are at risk. As Shireen was mentioning, young people are not the face of the infection right now. So I think that's being reflected in this risk perception. Next slide, please. How are they practicing prevention measures? As I mentioned, there has been, ongoing campaigns to promote awareness about what people need to do to prevent them getting infected. So there could be some bias in the report of whether they are practicing or not. But even then, we see that over time, between rounds of survey, prevention practice improved, but it remained low. For example, the proportion who reported that they are practicing like social distancing, washing hands frequently, and started using masks, all these three measures, we just see only 60% in the second round of, 60% of the males reporting that all three measures they are practicing, and far fewer females reported these measures, like 25% in the second round. Females are finding it more difficult in keeping a social distance, probably in the households where there is so much of crowding, and it's very difficult for them to practice this. I have not put it in the slide, in the figurative, in a figure, but we looked at, by different characteristics who are able to practice these prevention measures. Interestingly, no more than 2 out of 5 young people with even secondary education reported practicing all 3 measures. Next slide, please. So now let us look at how COVID and the containment measures have impacted young people and their households, jobs and livelihood, food security and health. Some of these insights, they reported on the household in general, and sometimes they report, some questions they responded, personal impact. So this slide shows about households' loss of job or livelihood after the COVID, affected the country, and particularly after the lockdown was imposed. And you will see that a lot of them reported that at least one household member lost his or her job or livelihood. Like 55% of males and 68% of females in the first round said their family lost job and their income earning opportunity. And when you compare the 2 rounds, more males reported that over time, the job loss increased, like 55% became 73%. For females, it's almost the same proportion. And as a result, of this job loss and income earning opportunities, we see that households were constrained in terms of having financial resources to survive longer. In response to a question on, what do they think about their resources will enable them to survive, how long? It's about 3/5 of the males said they have resources sufficient to survive for more than a month, while only 2/5 of the females reported that sufficient resources to survive more than a month. Next slide, please. And in the second round of the interviews, we asked them questions about their food security at the household level. And you would see that about 1/3 of the respondents reported that they experienced food shortage in the month prior to the interview. And about half reported that they have reduced food intake. And in fact, more females reported reduced food intake than the males, like 56% of the females compared to 40% of the males so reported. And in response to a question about what are the items that were reduced as a result of the economic constraints, we see that, a lot of them have reduced taking vegetables. About 68% said they reduced taking vegetables, fruits, non-vegetarian food, and pulses. So, which has a lot of implications for the nutritional status of, of this. Next slide, please. We also included a few questions to understand what is the impact on mental health situation as well as access to SRS service. And in this slide, you may see that I must caution that given that it was a telephone survey, we have only one single question about their mental health condition. So we asked them whether they felt lonely, depressed, or irritable, and if yes, how often. Whether it is sometimes or most of the time. And you would see in the first round, itself, we see that a notable proportion of young men and women reported that they felt lonely, depressed, or irritable sometime or most of the time. Like 34% of the males and about 45% of the females so reported. And when we talked to the second round, it increased among both males and females, much more among females. And as I mentioned that this study uses a cohort study, existing cohort study. And when we compare the mental health situation in 2018-19, not exactly comparable, but we see that between the 2018-19 survey and the second round of the telephone survey, the proportion who reported lonely, depressed, or irritable doubled among both males and females. Next slide, please. And there is a clear connection between the economic shocks and mental health condition. So you see that people who reported that they lost job are more likely than those who did not to report felt lonely, depressed, or irritated that. So also the people who reported food shortage at the house. So the economic shock that the COVID-19 and the containment measures are, imposed on the people is affecting the mental health condition. Next slide, please. The next few slides are talking about the access to SRS service, and it focuses on in our sample of married young women. And we had a question about whether they are currently using contraception, they or their husband. So we see that about a third of the young women who we interviewed reported that they are currently using a method. But I find the method more interesting in the sense that almost half of the current users are reporting they are using a rhythm method, and about 27% were already sterilized. So there's a very limited use of the reversible method, and we had about 1/5 saying they are using condom. All other different methods are reported by a very small percentage of young women who reported that they are currently using a method. Next slide, please. We also asked them about their access to maternal and child health services. A lot of them, reported that they did not require this service. So this analysis is restricted to those who said, yes, they wanted the service and whether they were able to get that service. You would see that the percentage who said yes, they got that service increased between the two rounds of the survey. For example, antenatal surveys, 12% said in the first round that they got the service, and it increased to 20%. The same goes for the child immunization. But you see that, there's a huge unmet need. Even though there is a improvement, and there has been, guidelines have been given by the health department how to reach out to women with these needs. This problem is recognized at the government level as well as at the NGO levels, but we still see that there's a huge unmet need. Next slide, please. Sorry. One more, the next one. So what are the implications of these findings? So definitely, even though everybody knows about COVID, there has been efforts to promote awareness. We see that the awareness has not been translated into practice in terms of, following all standard measures of prevention. So there is a huge need more creative social and behavior change communication activities, which emphasize the importance of adopting all standard measures of prevention. And these activities need to target women as well as other vulnerable sections of the society. Our findings also emphasize the need for saturating the reach of these social protection measures. A lot of families are affected, which in turn is affecting our young people also. And so there is a clear need for identification of households in need of social protection, increase the amount of cash transfers, and streamline the distribution. And a lot of young people, particularly those who migrated to, within India for job and all, are not able to work. So there is a need for creating local job opportunities. At the same time, innovative methods to ensure uninterrupted access to SRS services and access to mental health counseling is very critical at this stage of this infection. Next slide, please. I would like to stop with recognizing the limitations of this study. We definitely, as you have seen, low response rate for the telephone survey, but this is not typical of only for this study. Several of the telephone surveys have shown low response rate. And even though the parent study, which is the Udaya longitudinal study of adolescents, drew on a representative sample of adolescents, there is a selectivity bias in the respondents that we got for telephone survey. They are better off, they are better educated economically and as well as by socially. So that selectivity bias must be recognized when we interpret these findings. And we also find that for subgroup analysis, sample sizes are sometimes small, and service done over telephone, and the need for keeping the time of the interviews shorter and ensuring no too many sensitive questions. We could not have asked a lot of topics in detail. So these are some of the limitations of the study. And finally, I would like to thank you, all of you, plus my team members for this study. Thank you.
Sorry. Great. That was great, Santhya. Thank you so much. Interesting that increasing percentages who felt no risk and took no prevention behavior mechanisms, while the numbers in India are shooting up, especially in Bihar, where I believe another lockdown has been imposed. So lots of interesting findings. I'm sure we'll get a chance to talk more. Now over to Joyce. Joyce?
Yeah, can you hear me?
Yeah.
Okay. Can you all see my screen?
No.
Joyce, do you have your slide or do you need me to show it for you?
I have it. And it should.
You need to share.
I'm sharing my screen.
You share screen, you pick out your slide, and then you have to share it again.
Oh, that's what it is. Got it.
Try again. There you go. Yeah.
Can you see that?
Yeah. Can you put it on full screen?
Yeah, put it on full screen. Yeah.
It's on full screen on my end, so not too sure what's going on. Let's just get out of that and we share. Okay. Can you see it now?
Yes.
Is it on full screen? Okay. Sorry about that. Not too sure what's going on. By the way, thank you. And thank you everyone for participating in this webinar. So I'm going to talk you through a bit about the Wish to Action program, but starting off a little bit with the pandemic's consequences on programming. And what we have noticed with regards to the impact on program implementation is that country programs, especially in sexual and reproductive health, service provision have had to scale down activities due to COVID-19 pandemic. And this is partly because family planning and sexual and reproductive health and rights are not considered an essential service. And again, largely funds have been diverted to the COVID-19 pandemic. So we do see that this is especially severe for young people who mostly are not being reached through the traditional channels, especially static health facilities. And we've seen limited ability to hold outreach services or outreach facilities, which seems to be, based off experience, the most effective way of reaching younger clients and people living in poverty. due to the wider geographic reach. And even for facilities that do have full capacity, what they're experiencing is low client flow at these facilities, as clients are very worried about contracting the disease, and also due to restrictions on movement. And so what we're seeing is facilities have had to adapt and creating different standard operating procedures. And of course, the adaptation status really at this stage is dependent on where the country is with regards to the coronavirus. What we've also seen with regards to program implementation is that a lot of the youth events have stalled, especially because schools are closed. And we do know that the major challenge we now face with the coronavirus are adolescents not attending schools and spending more time at home and within the communities with very little of the activities that you're used to going on, which makes them quite vulnerable actually to a lot of the consequences that Shireen mentioned at the beginning with her presentation. And finally, we're seeing quite a bit of disruptions with the global supply chain. We're seeing quite a bit of commodity stockouts or reduced commodities within facilities. And these are just some of the consequences we've already initially noticed with COVID on program implementation. Now let me give you a little bit more on an example of a program, which we're calling the Wish to Action program, and just a brief background of this program. This program is aimed at delivering on 4 outputs that we see right on the screen. So individual choice, national ownership, access to services, and global goods. And for just because of time, I wouldn't go into more detailed on the 4 outputs. And the purpose is to provide through a comprehensive integrated approach to ensure that the most marginalized, especially women and girls, have equitable access to family planning and sexual and reproductive health. This program is being funded by DFID, and it's been implemented across Sub-Saharan Africa and Asia, and it's been implemented through a consortium approach across 2 work streams that we're calling lots, so lot 1 and 2. And in lot 2, which I'll be presenting the data from, is being led by IPPF. And so all the data that you'll be seeing today will be from the countries that are under lot 2. In this particular program, we're providing integrated services through 3 different channel types. So we're providing services through static facilities, through mobile outreach facilities, as well as through CBDs, mostly through the use of community health workers or community health volunteers. So why is there a huge focus on young people? And for the purposes of this presentation, young people will be only adolescents between the ages of 15 and 19. And really the focus of young people in the Wish to Action program is just, 1, young people make up a huge proportion of our population. Close to 1/3 of the world's population is under 20, which means there's a growing, they're facing growing SRH needs. We do know that though this is generally a healthy period of life for these adolescents, this is also the period where risky behaviors are initiated, which have far-reaching consequences for their health and well-being. And so there's therefore need for them to access services to avoid the risks associated with some of these negative outcomes. And as we're all aware, delaying first pregnancies and enabling young girls to choose how and when and to space their pregnancies means they can gain the education and skills not only to live a healthy life, but also leading to positive social and economic outcomes. So who are the young people that we're reaching with the Wish to Action program? Here I'm presenting some demographic data for young people. And just to note that this is facility level data. Over 95% of the adolescent clients are females, which probably is no surprise to anyone. And the data was collected between December 2019 and March 2020 through client exit interviews. And here we're looking at marital status of young people. And what we do notice is majority of adolescent clients who access services were single. So they're not yet married, or they were formerly married. So quite a contrast there. Only 3% of the adolescent clients were married at the time of the interview. When we look at the proportion of adolescents who have living children, we do see that 42% of adolescents are yet to start childbearing, while another 19% had one child. Only 2% reported that they had 2 living children. And then when we look at their education, of course, no surprise here, majority of our adolescent clients are still in school. About 33% of them either had some primary education or some secondary education. Now, if we look at FP service reach to adolescent clients in Q4 of 2019, so this October to December 2019 compared to our service reach April to June of 2020, we will see this first chart here is Q2, so this is October to December 2019, and the second chart is April to June 2020. And what we do see here is there's just a slight decrease in the proportion of services provided to our adolescent clients. Of course, there is variation between countries. And just taking a step back, when I talk of FP services, we define FP services for this particular project as either receiving a modern family planning method and or receiving family planning counseling. So when I talk of family planning services, that's what I'm referring to for this chart. And so we do see some variation or differences within countries, and though there's little decline overall, so 16.1% of services were provided to young people in October to December of last year compared to just 15.3% in April to June of this year. The biggest decline that we observe is in Ethiopia, where in Q4, and now when I talk of October to December, I'll refer to it as Q4. In Q4 of 2019, 9% of services were provided to adolescents compared to just about 4% of services provided to adolescents in the same period. When we look at Pakistan, we do actually see a slight increase in service provision to adolescents, and we'll talk a little bit about that in a future slide. Now we look at the family planning method mix provided to young people. What are young people most likely to uptake when they go to these facilities? We do notice that pills constitute over 60% of the method mix, irrespective of when the data was collected. And just to note that this data, the previous slide and this slide, is from a monthly survey statistics that is reported. And irrespective of the quarter, so from 2019 to current, pills constitute over 60% of method mix, followed by injectables and then implants. So what are we doing with regards to some of the program adaptation during COVID-19? One of the things that we're doing is in several countries, many of the country programs are working with national and local leadership to ensure the recognition of family planning as an essential service during the COVID-19 pandemic. An example will be of Zambia, where the team has supported the Ministry of Health to develop general guidance on the provision of essential public health services during the pandemic. So working with local and national authorities to ensure continuation of sexual and reproductive health services within our facilities. One of the other things that we're doing is building the capacity of additional service providers on youth-friendly services with quite a bit of focus on values clarification as well as attitude shift, which we know are huge barriers to service provision and to young people. Just to mention that this capacity building programs have mostly been virtual, but have been face-to-face where possible. And they have used traditional methods like recruitment of youth mobilizers and young community leaders to reach more young people who are even now more reluctant to come to these facilities during this pandemic. Now, once outreaches were allowed within countries, there have been more youth-focused outreaches that have been rolled out, for example, in Pakistan, and this has been done together with a helpline, which is specifically aimed at young people, but now it's actually even broader because of the COVID-19 pandemic. And in addition, we've used telemedicine and telecounseling call lines, which is being rolled out in several countries as an approach to reach younger clients. Another thing that we're doing within our country programs is adapting service delivery to young people's needs and priorities. For example, flexible opening times now that young people are not in school, opening or having more weekend clinics in addition to the door-to-door outreaches that I just mentioned. So there are a lot more mobilization activities in partnership with young youth leaders and academic institutions, taking advantage of the fact that these institutions are closed and to use them for the mobilization activities that we're doing. We've added more youth-specific radio and video content, adding more radio stations where young people can be reached with the information and targeted information, as well as including young people with disabilities, especially in all the interventions that have been focused on youth. Some of the specific country examples that I can mention here, for example, in Malawi, the youth-specific outreaches that are now being conducted with in agreement with Ministry of Health. Previously, these outreaches were conducted during the immunization clinics. The addition of videos in Malawi to reach more young people and to tackle the issue of internet access, these videos are offline and use Bluetooth. And in Sudan and Pakistan, they've recently created youth-friendly corners, which within their static facilities, and that seems to be effective as we're seeing a slight increase in family planning service provision to young people in Pakistan. So what is the way forward with regards to our program implementation during this COVID pandemic? One of the things that we're going to be doing is including young people to be part of talk show panels, which is being created now within country programs when talking about COVID and sexual and reproductive health. We do acknowledge that young people may not have all the solutions, but they are able to identify issues as well as meaningfully contribute to the conversations. We'll continue using the toll-free numbers that have been created and have been rolled out in more of the country programs for counseling and for referrals, especially for long-acting and reversible contraception, as well as using more of the online platform to share resources with young people. For WhatsApp, use of WhatsApp groups for provision of counseling as well, nesting youth providers at public health facilities. A lot of the toll-free numbers and WhatsApp groups and online resources we have to acknowledge might benefit a lot of the youth in urban areas. But nesting the youth providers within public facilities will probably reach more of our young people in the hardest to reach areas, as well as continue with telemedicine and provision of contraceptive services. I did present a bit of data from our client exit interviews that we collected in some of our countries between December and March of 2020, and we're yet to really mine that data to understand what's going on with our young people, and especially looking at how we reach the young, unmarried, and nulliparous young people who, as we see from our data, a lot of our young people are yet to be married and are yet to start childbearing. So there is an opportunity here with our programming, though we have to acknowledge that this will be more of an uphill task due to COVID-19, as a lot of them are not in school and a lot of the program thinking will have to change. I would have to actually though mention that I've given a general overview of our program and not really given full specific country analysis, but want to acknowledge that there will be differential impact of COVID-19 on program implementation across all our countries. All of the data that I have presented, it's pre-COVID, and though we're seeing as if there's really not a lot of impact of COVID on service provision or service uptake among young people, I think it's a little too early to assess that. And when we go back for our annual evaluation of the program, we'll then be able to fully say with certainty or assess how COVID is really impacting young people's sexual and reproductive health and what the outcomes will be. And I will stop here.
Thanks, Joyce. That was very interesting, and a lot of very innovative actions, which I see are happening in many countries, including some of what you said are happening in India. Now, I'm going to ask each of our speakers one question, and then Mary Ellen will take over and she'll ask the questions from the Q&A. So I'm going to ask the three questions together so that each of you can get a chance to think about them. So for Leticia, your findings showed that many more pregnant women than all women had healthcare vulnerability. I think you said 38 versus 22. And especially in terms of those who you said couldn't find available care. So it was less than 15 versus 30%. Why these huge differences? Were pregnancy-related services particularly affected? How badly in general were contraception services affected? For Sandhya, any idea about how your findings compare with more or less similarly aged women in the pre-pandemic time from your earlier surveys or NFHS? Or what? Would you say unmet need for services has increased? And for Joyce, overall, I must say, compared to all the other studies we've seen and estimates we've seen with regard to family planning reach, there hasn't been a drastic change in the 2 quarters that you compare. So I was wondering, how representative are the clients of the WISH program of the general adolescent population in your countries? And what are you doing that's making such a difference? So, thank you. Who would like to go first? Nobody?
I can go first.
Okay.
I mean, follow the order of presentation.
Oh,
That's fine with me.
Let's do that.
Okay.
Okay, Leticia?
Yeah, so thank you, Shreen, for your question. What we found from the in-depth interviews was that women were concerned with going to prenatal care. They were concerned with infection for them getting infected. So they were precluding themselves from going to prenatal care. But from the survey, since we asked, the options separately, we found that both they were precluding themselves, but they could not find availability in the clinics. So it's a combination of concern, fear, with resources being diverted to COVID-19, for example, for that kind of care. I want to mention that we also asked, but I don't have the results for that here. So, but if you are interested, please feel free to write me. But we do have in our questionnaire, in the survey, in the questionnaire, a specific question on whether women had issues obtaining contraceptive care, contraception, as well. So those are slightly different. So one is the prenatal care, and the other one is we do have that question as well. So we'll be looking into the impact, the proportions of women who report that they had issues obtaining contraception as well.
Okay, shall I?
Sorry.
So Shireen, interesting question. I should, start with recognizing the limitation, because as I mentioned, what we are finding from this telephone survey and what we have found through in-person representative samples are not exactly comparable. And also, we don't have data. For example, if I take the case of family planning, I mean, we have not collected data to estimate like unmet need in that true sense. We should be using that word in a very loose way. And what we find when I compare with the previous round of Udaya, which was done in 2018-19, and the last round of telephone survey, in terms of use of modern reversible methods, it is pretty same. And what we find, we had an additional question: did you need that? Even if they were not using a method, or were using a traditional method. I think somewhere between 1/3 to 2/5 between these two states is, yes, they need it, but they could not access it because of the restrictions on travels, because they fear about going out and they might get, and and also the reach of the service providers. I mean, like the frontline workers were limited. So clearly, I mean, in a loose sense, yes, there is a unmet need has increased. That's what I would say. And you had seen for the maternal and child health, among those who wanted, there's a huge chunk who said, yes, they wanted, but they could not get it. And in our earlier surveys, we did not find like, women not being able to get, say, for example, antenatal care.
Thanks.
I hope that answers.
Oh, sorry. Sorry, Sandhya. Are you done?
No, I hope, yes, I am done.
Okay. Respond to your question, Shireen. Yeah, it does seem like, there's just quite a slight decrease or decline in family planning service provision to young people. But as mentioned at the end of the presentation, I think that could be slightly deceptive because it's still early on in the pandemic, if you want to put it that way, just because a lot of the countries at different stages, some are experiencing another surge in COVID cases, and we really cannot fully talk about the impact COVID has had on service provision at this point, to really be honest. But I would say we have tried to adapt to the COVID. We have tried to adapt our program to what's going on with a couple of the areas that I've mentioned, and really the main idea is to try and minimize disruption with service provision as much as possible. And that has been different across the different countries, and that's why you're seeing different numbers across the countries. But I would say it might be slightly deceptive to say there are no drastic change. I just think it's a bit too early to actually see any impact on service provision at this point.
Okay, thank you. Mary Ellen, will you take the Q&A or shall I?
If you're comfortable looking at the Q&A at the top questions, you can do that.
Okay.
Do you want to? And yes, go ahead.
Okay, so we have a question for Leticia from Diego Iturralde. Sorry if I misspelled your name, mispronounced. Did you find that asking questions about reproductive health and fertility is a sensitive issue that people were unwilling to speak about? And if so, how did you handle such a case?
Thank you, Diego. So we should answer each one of them, right? Yeah.
Yes.
So thank you so much for this question. This crossed our minds the whole time doing this. So I have slightly different answers for the in-depth interviews versus the phone interviews, because the in-depth interviews were conducted over Zoom and were video recorded. And the interviewers requested the respondents they scheduled the interview, requested them to be in a private place in their houses, if at all possible. And the phone interviews, on the other hand, they were not previously scheduled. You know, it was at the spur of that moment. You got the interview, you got the phone call. So there's a slightly difference there. So we actually cut lots of more sensitive questions that we had in the questionnaire. But we feel that it could go either way, in that if we had a face-to-face household questionnaire, in that the interviewers would go in the household of the respondents, oftentimes what we see in the literature is that privacy is an issue, especially for people living in lower SES, you know, families. They don't have places to go in the house, whereas over the phone, nobody else knows what women are responding. In fact, they are answering, but nobody knows. So it can go either way in terms of the effect of more sensitive questions. And I want to say, so there's the classic questions that we ask on whether women have ever had a sexual relationship. And we intentionally left that we changed the order to ask that question at the end, and we did cognitive interviews to make that sort of change, not at the end of the questionnaire, but at the end of that one section. So we waited for the respondents to warm up to the interviewer, you know, over the phone. But all of that to say that we think it could go either way. It could actually be helpful in some cases because nobody's really listening. They are on their phone, but it could go the other way as well. And we took the care that we could in terms of doing cognitive interviews first and changing the questionnaire and seeing what we would get. So yeah, thank you.
Thank you. Santya, Dr. Somayajulu is asking, how would the profile of those respondents who refused or did not participate in the telephone interview survey compare with those who participated?
So there were a significant difference in terms of the socio-economic characteristics of those who participated and those who did not. As you see that this is a mobile phone based, and access is not in terms of ownership is universal. So it is skewed towards those who had an access on phone in most cases. And we did compare the samples who were interviewed and not interviewed, and we found that the ones who were interviewed were better educated. They came from better off households economically, and we also had more respondents from the urban areas. But refusal of those who we could reach, as you have seen, was very small. It is not being able to reach and not having, the telephone numbers which are functioning.
Okay, thanks. So you would say that your results are actually conservative because you're
Absolutely.
getting better educated.
Absolutely.
A question for Joyce from Tima Zagambo. Joyce, how adolescent-friendly are these services, especially in Africa with the huge problem of digital divide hindering online access to services?
I guess the definition of adolescent-friendly can be taken in many different ways. But the adolescent-friendly services are quite dependent on the country, actually. So there's not one for every particular country. And in some of the countries, they do have specific corners, like we saw in Pakistan, that is just for young people, with youth providers being trained to provide the services to young people. In other countries, they're providing these services through different avenues. Some use skits, weekend clinics, which means these clinics are operating on the weekends. And that was particularly when young people were in school, and that has now been adapted for the young people who are out of school, since majority of them are out of school. And so, yeah, it really varies by the different country, and it's been adapted whether within the health facility or within the community to fit the needs of young people. Now, the fact that many of them might not be able to access online resources, I think that's particularly true for adolescents who are living in rural areas, and that's why the door-to-door outreach services were rolled out in this, I think, the last quarter, to reach these adolescents who may not be able to access online resources.
Thank you very much, Joyce. Mary Ellen, are we done? I mean, for time. There are some more questions, and maybe the speakers can answer them.
Yeah, we can go on if some attendees are willing to hang on. I think we've got about 94 attendees left, so maybe we can answer one or two more questions. For those who have to go and who've asked this question several times, the video will be made available on the IUSP website, as are all the videos from all of our previous webinars, if you're interested. And if our panelists agree, and they're kind enough to agree, we sometimes also make the PowerPoints available, but only if our panelists are in agreement with that. So why don't we ask a few more questions? I'll let you take the floor, Shireen.
Okay. Before I do that, Mary Ellen, everyone seems to be interested to know, can we get certificates for participation?
No, we do not do that for the webinars. It's just not something that's possible. We don't know whether people are actually watching it or not, and I'm not sure what value it would have. So no, sorry.
So a lot of people in different ways are asking about program implications, policy implications. How can we address young people's needs at a time when countries are so stressed with addressing the pandemic? So that question, I think, was posed actually by Professor Sekar to Santya, but it applies to all three of you. So maybe you could all three respond. Sandhya, could you go first?
I mean, true that, the public health system in particular has been stretched to meet the prevention and treatment and care of people who are, infected. But at the same time, when we are talking about young people, there are multiple ways of, reaching to young people. For example, with information, we see that, increasingly young people uses, the digital media. There is a way to get to them, getting back to those informational needs. And in terms of, services also, I think we shouldn't be restricting ourselves that only the health system, the health workers should be able to meet these needs. There are other players at the community level, particularly the involvement of the Panchayati Raj in terms of the local administration, in terms of ensuring the access to services. I'm talking again from an India perspective for young women or young people, So that is a group whom we could drop in. And we also have these groups like self-help groups. I think we need to think about what is the existing structures that are not, so stretched for meeting the treatment and care, and make use of them to meet other needs. But if you don't use those alternatives, we, as Shireen said in her introductory presentation, the implications are huge. And we should not feel constrained with the health system has to be responsible for the SRH needs or the mental health needs for adolescents and young people.
Joyce?
Well, I actually think the show must go on. I do understand that the public health system is overwhelmed, but I think it's just finding ways of reaching young people even within the pandemic, because the consequences are huge. I mean, in Kenya recently, the news was about thousands of teenage pregnancies, the teenagers who gotten pregnant, and that was from antenatal data, and I think it was about 50,000 young adolescents. And so I feel, though acknowledging that the public health system is overwhelmed with the COVID pandemic, I think it's finding the innovative ways of reaching young people. And as mentioned in my presentation, that's what we're trying to do with reducing, in certain countries, the in-person service provision by moving to telemedicine, telecounseling, using WhatsApp groups for counseling, and referring or using referrals then when a method is being uptaken. So I think there are ways of going around it. We just have to find that innovative way of reaching young people.
Leticia?
Yes, thank you. And I agree with my panelists. I would say that those points apply to the case of Brazil as well. I want to add one comment that's specific to Brazil, which is that, so Brazil faced the Zika epidemic and is facing now the COVID pandemic in very different political conditions. And I'm not saying by any means that Brazil was exemplary in handling the Zika epidemic, but it was a very, and there's literature on that, that the role of the unidades de tratamento, the treatment units on the communities and neighborhoods in terms of prevention and passing information was excellent in the country in terms of policies and provisions and information during the Zika epidemic. Right now, I just want to point out that the current government has been sort of like destroying all that system that was in place, the public system. And I would be dismissive and irresponsible if I did not mention that in such an international forum, that this current government is defunding health policies, and the way that the COVID pandemic is being handled in the case of Brazil is extremely dangerous for the country, and how the public health system has been defunded. And it's yet to be seen the consequences of what's going on there now. So I just wanted to point that for the specific case of Brazil.
Thank you. I think we're losing our participants. And so let's close. But before I do that, there seem to be a lot of people wanting to know if the PowerPoints will be available. So Mary Ellen, over to you.
Yeah, as I mentioned earlier, if the panelists agree, we also make the PowerPoints available and the videos. There's a page on the IUSP website for the past webinars, and you can download them from there. You may also get an email from Zoom about this. Also, as people sign off, you're going to be asked to fill in a evaluation of this webinar. It's partly to find out whether you were able to, if you had any technical difficulties accessing it with connectivity, and then also any suggestions you might have for this webinar or for future webinars. And we also invite members to come up with their own webinars and let us know about those. So we hope to hear from you all soon, and thanks for joining us today. And I'm now going to end this webinar. And thanks so much to all our panelists and to Shireen for putting this together, and to Cynthia, Joyce, and Leticia for their really interesting paper presentations. It was great. Thank you all so much, and enjoy what's left of summer for those of you in the Northern Hemisphere.
Yeah, this has been great.
Bye.
Thank you. Have a good one. Bye, guys.
Bye.
Thank you so much. Have a good day. Bye.
You too. Bye. Okay, off we go.